Hi there, folks. This is Dr. Ellenburg. Welcome to our medical show here on Fox News Talk 1020 AM. Also find us on FM at 95.5, and also find us online at foxnewskoan.com. That's foxnewskoan.com. You can live stream us on the web to your desktop wherever you're sitting. Welcome to today's show. We've got plenty to talk about. Some reminders before we get started. During the week, you'll find me at the Ellenburg Center for Natural Medicine. Our phone number there is 563-2366. Our website address is drellenburg.com. That's drellenburg.com. Check us out. List of our services. We have suggested websites for you to visit and some reading material you may want to also go peruse. And also we do have some archive radio shows where I am working on a project that hopefully will be finished in the next, I'll give myself some time, say 6 months tops, but to start putting some of these shows more into a podcast type setup. Put them on the site at times, a little bit of a hassle on my end, so we'll be coming with something different so you can access those, and they will be free wherever they are at. So once again, it's drellenburg.com. I do see patients at times in Palmer and monthly definitely in Kenai. If you have questions about times and dates, give our office a call at 563-2366. Again, this is a live call-in show. We do encourage your phone calls if you do choose to call with a medical question. Our number here is 522-1020. That's 522-1020. All righty, let's cover a variety of things here. I'm going to kind of skip around a little bit. One area that we've talked in the past, we always try to have some type of section here on the show talking about cancer. Because, one, that we do have a lot more people these days getting cancer, and if we can find ways to prevent things, the better. And what causes cancer, right? It's always the big question. Really, there are a huge amount of factors involved in that. And one area where we don't tend to think much about is where somebody actually works and how that might affect their cancer. Now, certainly over the years, from an environmental point of view, and this means from an environmental medical point of view, someone who works in a work environment that exposes them to various toxins or chemicals or fumes could cause cancer. But it's another one when we start working in an environment that, because we work a night shift, might actually increase our chances of getting cancer. And we've talked on the show here a few times over the last year, a couple of years that is, about breast cancer being increased in women who work night shift work. And now there is a new study out of Denmark. I'm sorry, not Denmark. It was out of Sweden. Hold on here, folks. Get this right. Well, I'm not sure. Okay, so it's out of Europe somewhere, excuse me. And looking at night shift work increasing the risk for ovarian cancer in women. And so we now have a link between night shift work and cancer, in this case being ovarian cancer. And as I mentioned, most of the work previously has been talked about concerning breast cancer. In fact, Denmark was the first country to pay out government compensation to women who developed breast cancer after long spells of working at night or working a job that disrupted their circadian rhythm. Many of the women in that compensation group were women who worked, I want to say, as flight attendants or nurses. And so this latest article talking about ovarian cancer and night shift work appeared in the April issue of Occupational and Environmental Medicine. And data in this study looked at women through the Surveillance and Epidemiology and End Results program called the SEER program, which is used in our country here to identify women with certain types of cancers. And in this study, the age group was about 35 to 74, and they were asked how many hours they worked specifically, and whether they had ever worked night shift work. And what was found in this very interesting study is that about 27% of the women who had invasive cancer had worked nights at some point in their life, as had about 32% of those who had borderline disease. Now, in the control group, it was about 22%, so we have a good kind of comparison. So the duration of night shift work ranged from anywhere from 3 hours to 4 hours a night, and common jobs were food and preparation service, office and administration support, and healthcare, for example. And the researchers in the study concluded that women who worked night shift had increased risk for both invasive ovarian cancer by almost 1.5 times more than those who did not. And the increased risk of certain types of cancers was also restricted to women over the age of 50 of certain types of ovarian cancers. Now, we don't have any suggestions specifically to say that the amount of time, is there a duration of night shift work that might increase someone's risk of getting cancer? We don't know that. And in this study, there were some women who hadn't worked night shift in several years who did develop ovarian cancer. So the reality is, at what point in time did it happen? And On a larger note, one thing when I see patients, I always want to find out how their sleep is and how they're doing overall. And there's a lot of people who have a variety of jobs here in Alaska, and some of those jobs definitely require working nights, unfortunately. And certainly in this group of people, they don't tend to be typically the healthiest. And I know I'm sure some of you out there may be working nights, or if you are, you're probably listening to the show right now either because you're probably sleeping. But the reality is night shift work is very hard on us. And I always ask patients, if you ever have a possibility of getting out of that, and obviously a lot of times you can't, it's impossible, the job that you do have, is to change that because it really disrupts your sleep cycle. It disrupts your adrenals, which are heavily involved in making energy for your body and other hormones. It really affects the secretion of melatonin, which is one of the combinations. In thinking about, why would night shift work actually even lead to cancer, and the discussion is really centered on what we currently know. And the reality is there's lots that we don't know. But what we do know is looking at things like melatonin. Melatonin is made in your brain in a gland called the pineal gland, and it's secreted in darkness. And we also know that melatonin has some very great benefits that even as a naturopath doctor, we use supportive therapies for our cancer patients, and one of those is melatonin. Melatonin has been shown to reduce side effects from chemo and radiation in a couple of studies. It's also been shown, besides helping sleep, to also possibly benefit a patient's innate immune system. That means their own immune system abilities to strengthen themselves. And so frequently it's used in a lot of patients who have cancer. So we do have some relations in melatonin in that direction, but in the direction of ovarian. And what we haven't seen yet, as far as I'm aware of, is any study in men who work nights and any increased risk of cancer. There might be some in the works currently that have not been finished yet, but that would be a very interesting group as well to see if there's an increase in that. It seems to be a kind of a correlation with reproductive type cancers in this case, with night shift working women, one being, of course, breast and ovarian. Now we have ovarian cancer added to this list, and there may be more of these things. So over time, maybe we can find out more about this, and it'd be good to find out ways if people have to work night shift. I know some people have to. There's no choice in the matter. What can they be doing to help out and decrease their risk of getting cancer? And certainly, I think it's worthwhile on those people who do work night shift of any group, male or female, to consider taking actually melatonin to sleep. At least you should be getting it at a certain time of the day versus not getting it at all. And there's even been a couple of studies that have been done looking at people who are blind from like long-term blindness, because they tend to have higher amounts of melatonin because their eyes are not able to process light and therefore affect the secretion of melatonin from the brain. So hopefully as time goes on, we'll find more out. And of course, we'll probably figure out there's some hormones that we're well unaware of, or some nutrients we're probably unaware of that can totally affect this in some fashion and increase the risk. But once again, if you work night shift work, be doing your things to decrease your risk of getting cancer. And certainly we can add to that group. The easiest thing to do for anybody in this group, that lineup, is to exercise. Yes, exercise. As we mentioned here on the show many times, even last year, we have talking about different studies where exercise, even with cancer patients who have been for prevention and even during treatment, having much better overall quality of life while receiving cancer care, or decreasing the risk of recurring, having cancer recur again if they do exercise after they've beaten cancer back. So important, good stuff there. And again, that appeared in the Occupational Environmental Medicine Journal of April. Okay, well, some reminders from the next piece here. If you have questions or comments about your health today or about our radio show, about our medical items, of course, our number here is 522-1020, 522-1020. Give me a call. I'll be happy to talk to you about your health or your medical questions. We'll wait for those calls. We'll move on here today. Since we're on the sleep category, let's kind of continue with that. And again, reminding us why it's important to have good sleep. And one thing I've never seen this study kind of say before, and it's appeared in the actually was at a National Academy of Sciences meeting, looking at lack of sleep increasing weight gain in patients. And so there's new research that's suggesting that people who don't have proper sleep may result in increased food intake and weight gain. And what happens in this case is that sleep disorders revolve in a lot of directions, right? Trouble falling asleep, trouble staying asleep, not getting enough sleep. All these factors can kind of come under the guise of insomnia or having problems sleeping, including even having night terrors, or in this case nightmares. Or people have sleep apnea, so many things can affect your sleep. hold that thought. We'll come back to the sleep and maybe a cause of weight gain. Take a caller on line 1. Mary, are you there?
Yes, thank you, Dr. Ellenburg. Hey, first of all, I want to thank you for your contribution to our community. I really look forward to Mondays.
Thank you.
And I have 2 questions, totally unrelated, but one is about melatonin. Like the melatonin spray, something similar to what you offer in your practice. Is there any duration of time that you should or should not take that? I mean, can you take that indefinitely, or is it something that you don't want to take more than a couple months, and then you want to act on it?
Well, I've known patients, that have seen me over the years, and even some before they ever saw me, who were taking melatonin for a very long time. I mean, nightly, and I don't really see an issue with that. One thing about melatonin is you did mention the type that's available. So I know Dr. McCullough on his website sells a liposomal melatonin, and we use a company called ReadyZorb that also is a liposomal melatonin. For those that don't understand what that is, it's a much more absorbable form of melatonin because you literally wrap it, encase it in a fat, in the way it's made, and you can spray it under your tongue, get much better absorption, and take actually less melatonin. Oral melatonin that's not liposomal still works. You just take more of it depending on the person on that part.
Oh, okay, wonderful. I just want to make sure it wasn't something that would build up in a toxic way after a long time.
No, not that we're aware of. So.
Okay, wonderful. And the other question, I had a teenage daughter that had recently been traveling in Ecuador, and then she took a trip over to Peru, and she got a tattoo over there. And about 10 days later, she had a fever for a couple of days, and then a headache that lasted 4 days. And she went over to one of the medical clinics when she got back into Ecuador, because the headache didn't go away. And it was substantial enough that was preventing her from, her activities of the day. And he just basically gave her some injection that relieved the headache. They did urine test, and it came out okay. And then I think they took blood, but she went just a day or two before she was coming back to the States. So I don't think she ever got any results on that. But is that something that you think we should follow up on? And if so, what kind of time frame should we do that in?
Yeah, I know that in discussions with people getting tattoos in general, there's always the discussion of sterility. If whoever the tattoo artist is, are they using proper sterile technique with their artistry? Are they reusing? I mean, that's been discussion over the years, and the only concern is it sounds like, and it may be totally just coincidental, possibly, right, with her getting a tattoo and having this happen, but it did happen at the same time, and is that she contracted some type of virus. Mm-hmm. If someone was reused. And, one of the biggest concerns typically would be looking at hepatitis. Mm-hmm. And, if she'd, come down with that, I would definitely think it'd be more dramatic. But at some point in time, it may be important for her to do a hepatitis antibody panel, specifically for hepatitis B, because hepatitis B and C are what are transmitted via blood. Hepatitis A comes from food. So she wouldn't have gotten that. And she had a fever. Epstein-Barr virus, or mono, can be transmitted pretty easily. So that's certainly a possibility at the time. And you can even do a panel for that that would let somebody know if they've been exposed to it. Versus she's healthy now. So if she did it now, she wouldn't be having some positive antibodies for that. But she could have antibodies demonstrating she may have had it in the past. Those are my early thoughts on this. I mean, is her health good now?
Yes, and the whole situation only lasted medically about 5 days.
Okay.
And she was on an anti-malaria and had been on it for about 6 months. So I don't think it had anything to do with possible infection there. And it could have just been totally coincidental.
It's possible. Absolutely.
New area. And I just wanted to double check. She's pretty young, and just wanted to double check if and if we were going to do any tests, is there a certain incubation period, or is it something that you might want to get done right away?
How long ago was the episode of the fever and the headache?
Just about a week, around the 18th, give or take, of this month.
Yeah, I mean, as far as checking anything that I've mentioned, it would be something like 3 or 4 months from now, type of a thing.
Oh, okay.
Yeah.
Okay.
Yeah.
Well, that's wonderful. Thank you so much for answering my question.
Yeah, no problem. Thanks for your calls.
All right, ready. Bye-bye.
Okay, bye-bye. Yeah, interesting there. Give it some time and see what kind of comes out as far as her symptoms or anything. But as far as follow-up to see what happened, again, it could have been totally coincidental, but it certainly is something to keep an eye on. The one thing, too, with hepatitis, just to mention in general, is that people can have elevated liver enzymes for a variety of reasons, but also can be because of hepatitis, which is an infection you can get in your liver specifically. And again, with the melatonin, just reminders out there again, so liposomal melatonin again is where melatonin. A good way to understand why would making the melatonin fat soluble make it more absorbable, and that's a question which we should answer. And it's how that works is the entire lining of your mouth, into your tongue, into your gastrointestinal tract, that the cell wall, the barrier, is made up of a lipid membrane, a fat membrane. And so when you take something like melatonin, where they've been able to encase it in type of a fat, I know it sounds kind of strange. You're spraying fat into your mouth. Well, it's just a way of describing it, but literally encase that in a lipid soluble substance. You can spray it under your tongue, and by putting basically a fat on top of a fatty layer, you get good absorption. It's like putting oil on top of your skin. It absorbs into the skin, right? Like some type of a hand cream or olive oil, for example. Even that will absorb into your skin. It's the same kind of it's kind of like an analogy to the same thing. So the melatonin can be taken that way very well. And the one company we did mentioned ReadyZorb, and the other one I know Dr. McCullough also sells it on his website, and there may be a few others out there now as well. It's getting kind of more popular. They make vitamin C like this now as well, called liposomal vitamin C, which can be very effective in getting more in the patients. And also one of my favorite herbs, turmeric, is also being made these days by a few different companies in a liposomal form to enhance its absorption. Turmeric's great anti-cancer. It's good for your liver. It's good for gastrointestinal health. It's a phenomenal anti-inflammatory, so a lot of good things with that. All right, let's get back to the sleep here. Thanks for the call again, Mary. And, sleep disorder may be being linked to weight gain. And we kind of went over, there's various ways that somebody's sleep can be affected. And what they found in a very small study that was very recently done was looking at following adults within a sleep lab, basically, for a 15-day inpatient study. And each person in the study experienced basically 5 consecutive nights of inefficient sleep to mimic the effects of a long work week was what they were after here. And the researchers in the study reviewed the data on the participants' food intake, energy expenditure during the days they were having inadequate sleep, and compared those from nights of adequate sleep. So out of the 15 days they were there, 5 of those days they had poor sleep. And what they found out is that when insufficient sleep occurred in the participants in the study, their food consumption actually increased beyond what was needed for normal energy balance. And it particularly increased the night after eating dinner. So that increased at night after eating dinner. Okay, right. And as far as weight gain, the average weight gain when you had a bad night of sleep was about 0.82 kilograms, which 2.2 kilograms in a pound. So we're talking about like a half a pound of weight gain. And what was interesting, too, in the study is that lack of sleep actually affected women more than men. And weight was maintained in women who received adequate amounts of sleep but increased during nights of insufficient sleep. And then they talk about basically what are some type of integrative therapies that can be used to help people sleep. But a bigger piece with this is if you're getting poor sleep on a regular basis and you're trying to lose weight because you want to, it could be one of the problems why you're not easily losing weight is because you're not sleeping well. And if that's increasing, hormones that are going to decrease the satiety, feeling of being full, or might be eating more. And furthermore, we do know also that lack of sleep can affect how your body burns glucose, how your body burns fat. In this case, outside of the fact that people actually in the study were eating more when they didn't sleep as well. Beyond that, too, is talking about the timing of the day of the meals. And later on here today, we'll have another article, I think, on that, talking about that. But the biggest thing is getting back to what can you do for sleep. So the earlier call talked about melatonin. Again, your body makes melatonin, but you can take more of it. We've also used in patients with very good success an amino acid called glycine, not lysine, but glycine, Glycine. That's been very helpful in a lot of patients for helping them get relaxed so they can sleep. Magnesium is a wonderful mineral your body uses a lot of every single day. And in some patients, they'll take magnesium actually at night and end up having more restful sleep. And over the years, when we have patients come in who have a lot of leg cramps or cramping at night, magnesium tends to, not always, but tends to be the main culprit. And the added benefit of them taking magnesium prior to bed is they tend to sleep better. And so that's been helpful as well in a lot of patients. And then there's a whole variety of things out there. There's another herb, valerian, has been used for sleep in many variety of studies as well. So there's many things to consider taking for sleep versus having to take some type of a prescription sleep medication But I would say the easiest ones out there probably are going to be glycine or magnesium or melatonin. So consider those if you're having trouble sleeping. And the biggest thing is, why are you having trouble sleeping? So remember, focus on that. If it has to be with stress, with work, or with family, or whatever it is, try and figure out what those stresses are and remove those things, and not just treat the symptom of having insomnia, right? However, if you're deficient in magnesium, maybe that's why you're not sleeping well in the first place. So that could be a possibility as well, or being deficient in, say, the melatonin. So good to consider that. We've got about 3 minutes before the bottom of the hour here. Let's go over a quick one, and we'll get back to. We're going to go over thyroid break today, but an interesting article that appeared, actually was at a public health meeting, Epidemiology and Prevention, Nutrition, Physical Activity, and Metabolism, 2013 scientific session. So quite a mouthful there, but article was entitled "How Sugary Drinks May Explain Over 180,000 Deaths Each Year." And this was a very large study looking at the amount of sugary beverages that people consumed and what the major effects were on health, with the biggest ones being an increased body mass index, which was also linked with diabetes, cardiovascular disease, and cancer. And this study was started sometime in the mid-2000s, and they found out that basically by 2010, when it finished, that 132,000 deaths from diabetes in the study, 44,000 deaths from cardiovascular disease, and 6,000 deaths from cancer in the world could be attributed to drinking sugary, sweetened soft drinks, fruit juice, or sport beverages. A variety of things. Now, they didn't break it down so much per country, although I think that during a time period that was used, about 25,000 was the number that came out for the U.S. specifically. I'd say it's probably a lot higher than that. It's very hard to measure. I mean, you're talking about someone drinking, a sugary drink over a long period of time, and there can be a lot of confounding variables along the way that may affect them, why they might get diabetes or get cancer or cardiovascular disease. But this is a reinforcement, once again, that, as a clinician myself, telling patients, hey, you want to really lay off these things, and really a soda pop should be kind of a treat and not something you drink every day. Like, I'm always interested when I drive to work watching people, but someone next to me, drinking a soda pop at 8:30 in the morning. Not the best thing to be doing for yourself. Especially if it's got sugar in it, because it's going to raise up your glucose pretty quickly. And furthermore, aspartame, if it's a diet one, people say, well, I drink a diet soda in the morning. Well, you know what? That's been linked to cancer. So, you're better off drinking water, green tea, or something like that for the morning. But really looking at, whenever I can find articles, and there's plenty of them out there talking about the effects of, soda pop and reasons to stay away from it, I'm going to talk to you about them, because we shouldn't be drinking them in the first place other than having it as a treat. And I understand that. I'm not saying never have them. I'm saying there are many people having them way more than they should be. And especially kids, when they're like 11 and 12 years old, having a couple soda pops a day, that's a lot of sugar in there, especially affecting their teeth, affecting, their ability to focus and stay concentrated on something when they're sitting there, jacked up on a bunch of caffeine and sugar, for that matter. So, again, a reminder why you want to limit your soda intake. And there's a nice little song to remind us of having a good night's rest. We'll be back here in a few minutes.
Bring me a dream. Bum, 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 bum. Make him the cutest that I've ever seen. Bum, 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 bum. Give him two lips like roses and clover. Bum, bum, bum. Then tell him that his nights are over. Sandman, I'm so alone. Bum, 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 bum. Sugar, oh honey, honey, you are my candy girl, and you got me wanting you.
Hi there, folks. This is Dr. Ellenburg. Welcome back to the second part of our medical show here on News Talk 1020 AM, 95.5 FM. You can also find us online at the foxnewskon.com for live streaming on the web. If you have questions about your health today, give us a call here at 522-1020. It's 522-1020. Okay, well, before the break, we were talking about a variety of things today. We were discussing about sleep, reason why I don't drink soda pop. That's a good reason why I shouldn't be doing that, except as a treat. And let's talk today about my favorite topics to discuss frequently, and that is low thyroid function, or hypothyroidism. And this will be a two-parter. We'll discuss this today and another article for next week to talk more about this as well. But I was reading a primer through Medscape for clinicians on just treating and hypothyroidism in general. And what I'd like to kind of go over again is some reminders for patients out there that if you are experiencing these sort of things, it's worth bringing up to your provider to make sure your thyroid gets checked out and then tell you the drawbacks, even with thyroid testing. But a lot of people, so first of all, your thyroid gland's in the base of your throat. So if you put your hand on your chest and kind of bring it up to where you have your ribs and you have your sternum, and that kind of falls off, and there's a little notch called sternal notch, kind of right behind your finger right there is your thyroid gland. And the thyroid glands, when the first glands develop in our bodies, we're inside mom gestating, and it does a tremendous amount of work in the direction of our metabolism, how we burn energy in the body, because thyroid hormone affects how your cells do that in every part of your body. You cannot live without a thyroid gland very long, maybe about a month or two, and you will pass away due to extreme hypothyroidism. So it's important for life to have it. And those that have had theirs removed due to cancer or some other condition have to be on thyroid hormone for life. But some common symptoms we can see in people with low thyroid function can be kind of a cold intolerance, or they're sensitive to the cold, or the first person in the room putting a coat on if it's getting chilly out, or they're always wearing a coat wherever they're at, or being cold even in the summer sometimes. Dry skin, that's not just in the winter. Fatigue, which can be a lot of different things in medicine, but fatigue can certainly be associated with low thyroid function. Muscle cramping, I would also add that list. Joint pain can also be involved. Constipation is frequently seen in a lot of patients with low thyroid function, and constipation typically is somebody who's not going every day. And if you eat food every day, you should have a bowel movement every day. That's how it should typically work, unless you have some other problem going on. Voice changes can also be affected with low thyroid function. Poor memory, brain fog can get involved. Allergies can also be associated with low thyroid function. And people who have very, very severe thyroid problems, low thyroid that is, they can also actually develop carpal tunnel syndrome. They can develop sleep apnea. And they can also have, besides being severe, low thyroid function can also affect women's fertility issues if they're trying to get pregnant. And it can also affect frequency of menstrual cycles, usually by making them more irregular. There's probably a few there, but those are kind of one of the big ones as far as it works. And so your thyroid gland puts out three hormones. One's called calcitonin, another one's called triiodothyronine, another one's called thyroxine, and we use those names instead. We say T3 and T4 for short. And it's the T3 and T4 that are stimulated by a hormone from your brain. The pituitary gland specifically secretes a hormone called thyroid-stimulating hormone, or TSH. And it comes down to your thyroid gland through circulation from the brain, and it tells thyroid gland to put out T3 and T4. They go out in the body, do their work, and eventually come back to the brain and act as a feedback to decreasing the output of TSH. So we call it a negative feedback loop in medicine, but it's kind of a very balanced act taking place. Testing typically revolves around looking at one test called thyroid-stimulating hormone. And as clinicians, typically if we see that value and we say, well, if it's between 0.4 and 4.5, we'll say you're normal. And if it was higher, that would mean your thyroid gland is not making enough thyroid hormone, and therefore secretion is not being suppressed from the brain and it's increasing. We would call that thyroidism. It's kind of confusing, but that's how it works. Now, a couple of things about that range I said for TSH. I've mentioned on this show many times that the range for TSH is too wide. In fact, there's been discussions to lower it down even to 2.5 or 3.0, which would bring many people into the category of being clinically diagnosed with hypothyroidism or low thyroid function. And that is something that I look at frequently in my patients, that the TSH comes back and it's not under 3 and it's above that, we're going to say they're having some thyroid difficulties and try and look at what we can do to help out the thyroid gland. And also with the testing for thyroid function, it's important to have autoantibodies ran, and that's to check for any autoimmune disease. Autoimmune thyroiditis can be very common in a good portion of the population, and usually is undiagnosed unless someone's running these tests. But a good thyroid panel looks at TSH, T3, T4, and autoantibodies as far as a good roundup of looking at thyroid function. Part of the problem with thyroid testing as well is that even though it can't come back in range, everything would, you could still have a thyroid problem. And that's when we start looking at things that could add more to the picture, such as patients coming in with a resting heart rate that is increased, or they have serum cholesterol that is increased, or they have anxiety or even depression. They could have sleep problems as well. And in a lot of patients, we can use these confirmatory findings to kind of add to trying to figure out, does this patient have a thyroid problem or do they not? And you can even see certain enzymes in the body as well that can be involved. Liver enzymes that can be involved and actually go down once patients are being properly treated with a thyroid disease. I mentioned depression. That's worth bringing up because that's a critical area. And anybody out there who's been diagnosed with depression, if you have not had your thyroid looked at clinically, it should be done. Depression is frequently patients with depression have thyroid disease. Not, how many, I'm saying, well, frequently, in this case, say 10, 15, 20% people with depression actually have thyroid disease that may be causing their actual depression versus just being depression. And so it's important to have that looked at as well. Anyone who has depression or being treated for it, make sure your thyroid function has been assessed properly, make sure that's not in that. So really an important piece. And so today we'll kind of leave it at that point as far as our primer on thyroid disease. Again, lab tests recommended for looking at thyroid problems, TSH, T4, and T3. We usually recommend getting the free levels of T4 and T3 checked versus total T3 and total T4. Okay, well, let's move along here today. Again, you get questions or comments about your health, give us a call here. It's 522-1020, 522-1020. You can find us here, of course, is 95.5 FM and also AM 1020 for News Talk. And let's talk today about my favorite little minerals again, magnesium. And we had mentioned magnesium earlier in today's show in discussions of looking at sleep and being used for nocturnal muscle spasms, even muscle spasms in the daytime could be helped possibly by magnesium. And I have talked several times here on the show, even over the years, and looking at people with cardiovascular disease, is there any relations to talking about magnesium? And frequently, and even there's some studies to back this up, like high blood pressure can be attributed to having low magnesium. Atrial fibrillation, that means basically your atriums in your heart are not firing properly, can be affected by magnesium levels. In a study that appeared, where does one come from here? I don't see it listed out. Here it is. It's in Circulation, and it came from the Framing Heart study, a huge study. In this case, looked at a certain group and the parents' offspring, and the average age was 44, and about half were women. And they were looking at increased risk for atrial fibrillation after someone's had heart surgery. And it says here, it is unknown whether low magnesium predisposes people in the community. I would say that it does, and what we've seen clinically over the years with patients. But in this study, they looked at 3,500 folks, half women, half men, in the study as far as numbers, and looked at risk factors. And during a 20-year follow-up, that's a long follow-up, 228 people developed atrial fibrillation. And they looked at their serum levels of magnesium. And a serum level of magnesium you usually want to have above 2, somewhere between 2 and 3. I don't find them to be very helpful. Frequently, I have seen them not let us know if somebody's actually low in magnesium, and I prefer patients to have a red blood cell magnesium done, RBC magnesium done instead, to see where things are at. But in the group who was having the atrial fibrillation problems, they were like somewhere around 1.77. For their serum level, which again isn't horribly low, but your body uses magnesium every single day in over 300 reactions that we actually know of. I wonder how many things it's involved in that we don't know of. I'm sure it's lots. But the RDA for magnesium is 350 milligrams a day, which is a lot. And many of us are not getting that much magnesium per day in our diet. It's hard to do. Most of it's coming from green leaf vegetables, for example, nuts and seeds. But in this case, if you have someone you know or is suffering from atrial fibrillation, typically what can happen is that a patient may even have to be cardioverted. We actually go in and literally burn out some areas within the heart to decrease these firing abilities. The patients might also end up, after it's been corrected, in being put on some type of blood thinner for life, because atrial fibrillation can increase your chances of throwing a clot out of your heart. Well, it would be great. It was just easy just to give magnesium to fix the problem, and it certainly might be. There it says here there are further studies may be warranted to confirm our findings and look at the underlying issues concerning magnesium atrial fibrillation. I'd say a few of those studies are already out there. That, if you have atrial fibrillation or know somebody who does, make sure they've had their red blood cell levels of magnesium checked for, or at a minimum have them do a serum magnesium level and see where they're coming from. And if they're low, let's treat it, right? Will make the atrial fibrillation go away, and might also help out their blood pressure as well, which is commonly we find in a lot of people. That and looking at potassium levels have also been associated with atrial fibrillation in some patients. So these things are worth considering in trying to figure out why you actually have this versus something going in and saying putting you on a blood thinner for life because you occasionally have atrial fibrillation. Well, let's look back at the cause. Let's treat the cause of the problem, not just treat the symptoms, right? That's what all medicine is about in the first place. A lot of times it's finding the time to actually do it that way is the big issue. Okay, folks, we turn today. It's Dr. Michael Ellenburg. It's our show here on News Talk 1020 AM, 95.5 FM. If you have questions about your health, our number here is 522-1020. It's 522-1020. We've got about 10 minutes left in today's show. If you got questions, now's a great time to call. Timing of food intake. I want to get to that one day before the time is up. We mentioned earlier that, by having poor sleep, this recent study is demonstrating that people are at increased risk of weight gain because it actually makes them intake more food than normally would. And we're not sure why that is, but that's what they found out from the studies. Well, another interesting point is trying to lose weight and the timing of food intake. When should you be eating if you're trying to lose weight? And in the International Journal of Obesity, which appeared in January of this year edition, looked at the evidence to evaluate the role of food timing in weight loss and how effective that actually is. And the sample looked at about 420 individuals who followed a 20-week or 5-month weight loss treatment program. And the mean age in the group, with a big plus or minus, was 42 plus or minus 11 years. So the age ranged from basically 31 to 53 was the age group. Again, about half were female and half were men. And they were grouped in these categories of, this is a European study called early eaters and late eaters, according to the main meal. And this is a Mediterranean study. And so they had about half of the people in the study were early eaters, and about the other half were late eaters. And late eaters were lunchtime before 3 o'clock in the afternoon was an early eater, which I wouldn't call it early eater, and lunchtime after 3 o'clock in the afternoon was a late eater. They also looked at the energy intake that people needed and how much was expended, appetite, hormones, sleep duration as well. And what they, of course, found out is that those who eat later in the day lost less weight in those 5 months and displayed a very slower weight loss rate during the actual timeline. Energy intake, diet, their energy expenditure and appetite hormones, and sleep duration were pretty similar throughout both the groups. But it was the late eaters more often than not eat a very energetic breakfast or skip it altogether in the first place. And I have many patients over the years, and even some current, I see new ones that we'll get talking about the dietary piece of our intake, and we're like, when are you eating your food? And do you eat breakfast? No, I don't. Do you eat lunch? Sometimes. Do you eat dinner? Yes, always. Oh, okay. Well, here's the thing. If you're trying to find some way to lose weight, if you're not eating breakfast, you're not getting your metabolism going in the morning. That needs to be happening. And I'll frequently hear from patients, well, I'm not hungry in the morning. And I will tell you more times than not, if you're not hungry in the morning, you're eating too much at night. You should be hungry in the morning. And one thing to reverse everything around is you start actually eating breakfast, and if it's going to be trying to lose weight. And furthermore, I'm not a big fan of people eating big dinners anyways for anybody, other than occasional get-together family. You may have more food then, but a bigger breakfast, a lunch, and a smaller dinner in comparison to the first two meals. You typically tend to burn less calories at night. So if you eat a bigger meal in the evening, you're going to have less energy output and therefore going to burn less energy and increase the possibility of weight coming on, or make it very hard to lose weight. And eating that breakfast is extremely important for getting that glucose metabolism working in your body. And literally, I call it priming the pump for the day to get that system really working, is eating a breakfast of some type, not skipping it. And certainly with dinner, some people who eat a big breakfast and a big lunch, you can almost skip dinner sometimes if that was the case. The idea of eating 3 meals a day, I don't know where it all began in the first place. There's been different food habits with individuals for millennia taking place. But definitely eating first thing in the morning is going to be a great benefit overall. And we find from the study right here, those who are eating late in the day, even eating a late lunch and a dinner, are tending the ones that's much harder to lose weight. And it makes sense that it would be the case. And here we have a study demonstrated that specifically. So again, you want to lose weight, eat less at dinner, more at breakfast, and you should be hungry at breakfast. If you're not, eat even less at dinner. So definitely consider that. Okay, folks, we've got about 7 minutes left in today, 6 minutes left in today's show. Questions or calls? Now's the time for those who want to do that or not. That's 522-1020, 522-1020. Last piece in the day, I want to talk about insulin resistance, because there are some things related to that a lot of patients at times, and due to some busy practices, people aren't getting the time to hear this from their providers, in that, how do I know if I have insulin resistance? And quickly, what is that again? So insulin resistance is where the cells, the main storage areas in your body for glucose, your sugar, is your liver, your fat, and your muscles. That's the main storage areas, okay? And insulin, so a hormone that comes from your pancreas, tells the liver, the fat, and muscle cells to store glucose. As far as we understand it today, that's what we think is going on, at least, how we look at things. And it's when those cells stop listening as well or stop responding as well to insulin that we tend to say somebody is insulin resistant. And insulin resistance can be associated with a variety of conditions. We know for sure it's associated with diabetes. You know it's involved in heart disease. It's been shown to be involved in gout, liver disease, and even erectile dysfunction in men. And what we begin to see kind of early on before somebody actually ever gets type 2 diabetes is these early markers of insulin resistance. In this case, they call them hallmarks of insulin resistance. Talking about elevated triglycerides, reduced HDL, increased LDL. They may have increased blood pressure, and they may tend to have abdominal obesity, where they actually put weight on their bodies more in the abdominal area versus somewhere else. And these are the early signs of that. And a lot of people question, well, why would I see those first, and then, what's going on? Well, again, as far as we understand things, when the insulin becomes not sensed as well at the cells and resistance is taking place, more is needed to basically, pound those liver, fat, muscle cells over the head, saying, hey, listen, take in this glucose. Let's put out some more. So your pancreas works even harder, puts out more insulin. Well, what begins happening in that person is that over a period of time, they begin to show these markers of insulin resistance. One being they're not burning fat like they used to. And so therefore the body wants to make it into things like triglycerides, like LDL. They're not burning fat like they used to. Now they're going to burn sugar more often. So they end up getting increased weight gain and having ineffective energy consumption in the body. Blood pressure can be involved, and if insulin's being secreted at higher levels, we know that also sodium retention in the body, and sodium attracts water, and so that can increase pressure in the pipes and lead to somebody having high blood pressure, long before they ever get an actual diagnosis of type 2 diabetes. Now, the important thing is, if you have any of these problems, if you have elevated triglycerides or reduced HDL or increased LDL or increased blood pressure or abdominal obesity, and you're concerned about if you have diabetes or not, or on the road to that, make sure when you get tested, they check your fasting insulin levels. Because you could have your blood sugar measured and say, oh, you come back, you're at 90, you're doing great. Well, meanwhile, your fasting insulin could be somewhere around 15 or 20, which is still in range, but in our book that I use as a guide, we're talking about someone being insulin resistant. Let's start treating that in advance. Let's try and prevent diabetes from happening in the first place, type 2. That's the important part, because once it's there, it's a lot harder to treat. And if we can do something before it shows up, we'll get much better effect. And we talked on the show almost weekly about diabetes and the cost of that to our country, and the cost of medical care costs are huge. They're massive. And it's not getting better. It's getting worse. And so we really need to be more proactive as a group, all of us together, in trying to better our health, so we will begin spending less money on the system for medicine in general and for our health, our insurance programs. I mean, most of us are paying the insurance premiums that we pay because we've got a number of people in that insurance company, as far as who insurees, who have poor health and raise up the insurance cost. If we could have a more healthy populace, we probably would get a decrease overall in insurance if they're a good insurance company. Those guys work. So that's a different story. But the reality is you can certainly do something sooner than later with insulin resistance than wait until it turns into type 2. And if you're not doing something, you are increasing your risk of cardiovascular. You're increasing your risk of getting cancer. You're increasing your risk of developing, eye diseases such as retinopathy, which can affect the retina in your eye, and people who have increased insulin have yet to have been diagnosed with type 2 diabetes. And you want to keep your eyesight as long as you're on the planet, okay? And so this collateral damage, this article was kind of written and summarized by Dr. Eliza. Right? Is it Dr. Eliza? I think that's what his name was. It's from California, Dr. Eliza, yeah. He points out is this collateral damage from different things involved with the fact that someone's insulin resistant. And you want to change that. And it's very changeable. And again, huge piece being diet and exercise decrease your risk of getting type 2 diabetes in the first place. And if you're trying to treat type 2 diabetes, using diet and exercise as the first piece in the puzzle to be doing properly. All right, well, folks, that's the end of our show today. I appreciate you for listening. Thanks for the phone calls. And we'll be talking to you next Monday. Have a safe week and drive carefully out there in the snow. All right, bye-bye.
A folded hand, a poker there. All new directions must go everywhere. Big round people in a cool little square. Or you can't cut it with a boat or a plane. Man, it's gonna take a new train. You'll be leaving on a new train, far away from this world of pain. And when you look out your window, you'll see your home, your baby, and your family. No melted ice.